Here we heard from Scotland. We're going to hear from Wales. We're lucky to have Andrew Smallwood here, who spent, I think, 25 years in the NHS in Wales. Initially in devices, a subject I'm close to my heart, I'm passionate about, especially evidence-based procurement, but now moving into rolling out Scan4Safety in Wales, and I'm sure going to talk about how that will benefit procurement and devices. Andrew, over to you.
Good morning. I think the advice is don't start a presentation with an apology, but I'm going to start with three. First one is I'm about 10 days post-COVID, not contagious anymore, so the brain fog is still there, so you'll have to bear with me. As a result of that, I can't remember who I stole the slides from and who I stole the ideas from. And the third apology is for all the brilliant presenters from yesterday. Thanks for future ideas. So I'm going to give an overview around where the programme sits within Wales, how the approach in Wales has built up. And I think I'm going to start that with a thanks to GS1, thanks to HCSA. They provide brilliant forums for us to share our learning. A lot of what's just presented there, I think I could have stuck on my slides as well. So I'm going to start with just giving you the context around who we are, what we do in Wales. So slightly different setup to England. I work for NHS Wales Shared Services. So we are a national organisation, NHS funded, and we look after our health boards and trusts within Wales. There's 7 health boards, 3 trusts. The health boards are integrated, similar to your integrated care partnerships that have been built up. The health budget and the population are similar to Manchester, 3.3 million people, around about 8 billion spend. This is pre-pandemic, but a lot more integrated within the way that Welsh Government and the NHS works. Shared Services was created formally back in 2011 with a view to bringing consistency, common principles, economies of scale across the back office functions within the NHS, allowing clinicians to do what they do best. There's a value-based healthcare ethos within NHS Wales. Allowing clinicians to operate at the top of their licence is key. There's no point in going through decades of training to be then an administrator and ordering products. So we try and make sure that we take a lot of that pain out of their world. Busy slide, but just a few stats in there. Across Shared Services, there's just over 4,500 of us. A budget of just shy of 500 million. We pay for overrides, or we process more than 95% of all of the payments that come out of Wales. And just to give you a sense of some of the services that we do, the area that I'm based in is two of the bottom two, the health courier service and procurement services. We process everybody's payroll. Pandemic, everybody was wondering how we deal with people, how we care with people. A part of our organisation was thinking, how do we keep paying people? People who are in the health service need income. So we need to make sure that all of that stress goes away and they're able to concentrate on what they do. And as I said, lots of this is built so that we do things once for Wales, and we take out a lot of the burden in the background. So we deal with all the legal cases. We've got medical examiners function. Our risk pool. We pay all of the claims from the NHS. So again, data is key. But the key thing that I suppose drives this, and we're not competitive between England and Wales. I mean, dodgy line-out push that led to a try the other week that I'm not bitter about. But in relation to health, I think there's a lot of things that Wales do really well. A lot of things that we learned from England. I think the Healthier Wales document, I think, was published before the English one, but actually has got some really good themes. Came out of Prudent Healthcare that was developed when Mark Drakeford was the Minister for Health, and it's all around making sure we do what's right for the patient, cause no harm, do what you need to do and do no more. But a Healthier Wales sort of built upon that, and the value-based healthcare approach that Wales have got in making sure that we measure the right things. We build our service around the patient base. care closer to home, diagnostics where they need to be. Lots of talk yesterday about PROMs and PREMs. Dr. Sally Lewis leads our Value in Health programme. Huge investment in collecting national PROMs, national PREMs. We were involved, some of the work I've done over the past few years with the team within value-based procurement. We did some work within ophthalmics, cataract surgery, one of the most successful procedures that's done in the NHS. If you ask the ophthalmic consultants, success rates 97, 98%. But then when you look into PROMs, the patient's satisfaction is somewhere around 12% less than that. And so then that shows us what is it we're not doing right. And then you start to dig into it and you say, no, actually, technically that procedure was spot on. But the patient expectations were not aligned with what you were going to do as a procedure. The patient didn't get the benefit for the amount of money that we invested in that patient. So again, it's making sure that all of the data is in the right place to inform the right decisions to carry out healthcare. That flows through into what we do. And I'll go through and just explain how we're getting closer in that space at the minute. So that was 2018. As I said, we've learned a lot from being part of this. I was a bit involved with a GS1 hug from 2016. I had put a few papers into Welsh Government to say, have you seen this pilot programme going on in England? Can we have one? And Andrew Goodall, the Chief Exec of the NHS at the time, said, we haven't got that amount of cash to learn the same lessons. Keep an eye on England, see how we're doing, and we'll build something off the back of what they're learning and keep me informed. So that was 2016, I think. I gave another paper back into him when Jeremy Hunt flipped it to a patient safety perspective around Christmas, around 18. At the same time, this was going on, so it was building some nice momentum. We were getting more recognition that this was there, but we had a few things to get on with to begin with. So back to basics. Base data was fundamental. Making sure we had the right tools to do the job was key. Like Scotland's mission statement, but what we decided to do was keep it succinct. Gather information today to answer tomorrow's questions. Bit of a Donald Rumsfeld, we don't know what we don't know. But if we start measuring it and we start keep capturing everything we possibly capture, then the second that we know what we don't know, we might have some information that can help us straight away. So that's where we as the team started to really get to grips with what we could do. And because I'm from Wales and it's value-based healthcare, I have to mention Michael Porter. So from his perspective, if you do nothing else, measure, and then that gives us the opportunity to analyse, learn, and improve. This was in the background. Obviously, this is something that's key. So those data standards from GS1 are helping us to bring together the 4 Ps that were talked about within the Scan4Safety programme. This is obvious. This is good stuff, and this was something that we bought into as a plan early on. In the background, within Wales, we were Brexit planning. Welsh Government's invested in a warehouse to help us get through that. So this facility is in Newport. You can see by the bottom line there, it's significantly bigger than what we had before. I'm ex-NHS supply chain as well, so I was involved in setting that up many years ago, and this was a different scale warehouse than I've dealt with. There's a whole mezzanine in there as well that we put one of the Lighthouse labs in. We run a medical pharmacy production unit out of there, and it's got our Brexit stock, our PPE, as well as 2 other warehouses. But actually, it's given us the opportunity to build a broader national supply chain modernisation programme that we entwine the standards within. As has been spoken about, all of this was sort of landing in preparation for one event, and then became absolutely paramount and critical in the way that we dealt with the pandemic. This was huge blessing, the amount of space that we had to bring in stock into Wales and to manage that. So now that was only loaned to us by Welsh Government to begin with, to do with Brexit. What we did, and I think Simon Walsh talked about this yesterday brilliantly, that I think the pandemic, as nasty and horrible as it's been, has really been a boost to the supply and logistics functions within the NHS. I think clinicians, Welsh Government politicians have realised that the power of the supply chain it's been reinforced now with what's going on worldwide. But Welsh Government went and bought this for us. So this was an old LG plant from years ago. They used to make tellies and things in there. So this is now the National Distribution Centre for NHS Wales. We've got 2 other warehouses for normal stock. We've got 3 more for PPE that will run down as things change. But this is a nice infrastructure that's being built. And what we are doing within shared services is building it with the standards in the background. That sounds easier than it is. So our Sarah Taylor, our systems manager for our warehousing function nationally, runs off and hides in a corner every time I say GTIN, because we've run our system without them for years, for decades. She's 20 years in this role, and what we do is built around previous failures, previous challenges, and all of a sudden this big scary language with all these lines and things that are coming in is a bit scary. So I think where we are with that is working through very carefully, methodically, making sure that as we bring in our new systems, they don't budge the old systems out of the way. They capture them, they embrace them, and they allow us to morph into the new world without any stop-starts. Same as the NHS, this service doesn't stop. You can't switch it off, change it all, and switch it all back on again. We run the air ambulance provisions out of there. We run Emmets, and the Health Courier Service circulates all of the vaccines to the centres, takes away all the sharps and everything else from there. So a lot of this operation over the last couple of years has been non-stop, and it makes cultural change difficult. Similar to what Scotland have just said, and I think this is, having worked in England, having worked in Wales, and I am Welsh, but Wales has got more of a coordinated feel about it. So we're closer to ministers, we're closer to Welsh Government. This is from Chris Jones. Brilliant, Chris. We bought into this really, really early on. And these comments were from probably 2019 when we just started to think about this. So off the back of the papers that I put into Andrew Goodall, Chris came to us and said, those papers, the MDR's coming, I think we need to do something. Can we start to pull a programme together, and can we start to think about how we start to capture all of these? I know the MDR, Brexit and all the stuff changed that, but the focus is still there. So Chris was a really good supporter early on, and together with Chris's boss, Sir Frank Atherton, our Chief Medical Officer, who's now the sponsor for our programme. So similar to Scotland, right at the heart, driven by medical. Chris has been really useful, and he currently chairs a group that we've got. I suppose just a snippet in there for Chris's dedication. We had a project board that was planned for a Friday lunchtime, and I got a message through from Chris to say, I'm really, really sorry. Can we push it back to 3 o'clock? So, yeah, no problem. So we pushed it back to 3. I was working from home at the time. So I thought, great, I can grab some lunch today. So I walked through the lounge, and he was on the telly giving the lunchtime address to BBC Wales. And then he came onto the project board in the afternoon and gave his profound apologies that he'd messed us around. And I just thought, that's exactly where we want this programme to sit, that people of that standing have got this amount of enthusiasm around what we're doing. So it's similar, again, lots of similarities to Scotland. I think around Christmas 2019, just into 2020, we put a paper out to chief execs. So Frank Atherton took it to chief execs to say, this is what we want to do. We want to crack on with getting this programme built. So we got agreement from chief execs that we could start. They agreed that some funding would be put aside. And then obviously the world changed, and everybody had to go off and do different things from March 2020 onwards. So we had a pause with what we were doing at that point, and then we picked it up in September 2020. The the business case, Chris wrote out to all of the medical directors across Wales. We had a project board that was made up of a management lead and a clinical lead out of each health org, and we built the specification, ran a mini competition under a framework for our inventory management solution, and Omnicell with SupplyX were successful in that. The business case then went through to Welsh Government and we secured the funding. What we did, and similar again, one of the big differences between Wales and England is when I got to Wales, I could open my PC and I could see everything that had been bought in Wales from one terminal. We have an Oracle system that's national, implemented and managed nationally, so we already have quite a good cohesive setup. Our central teams load all catalogues for all health boards, all theatres. Even if that catalogue has been generated by a local team, it still comes centrally to be loaded. And everyone in procurement in Wales works for us, so we're all part of that. The original target was to have all theatres in all orgs live by the end of 2022. That's 172 theatres across 22 major sites, and that would have been a challenge anyway. But we've not got near some of those sites because of COVID, because of the way that they've had to change the services, because of pressures. However, what we have been doing in parallel is to work through the other way. So we've gone through starting to change our materials management, starting to do the wards, change the wards around, with a view that there's a pincer movement to try and get coverage of all of this data signals into the system. Our new minister, Eluned Morgan, absolutely gets it. You can see, I'm not going to read it out because of time, but you can see that she gets that it's the Once for Wales approach that puts the right data in the right places for patient safety and for efficiency. I saw on Twitter this morning that she was actually at IP5 in Newport at our warehouse yesterday. We were sending off some stuff to Ukraine, so she was down there, and as I said a minute ago, the way that NHS Wales Shared Services is perceived off the back of the pandemic is different to what we've seen before. We're sort of plugging into other programs that were already up and running. So this is in one of our first project boards that we had with the clinicians. We had the Chief Clinical Information Officer from Cardiff shot me down in flames in one of my first project boards and said, just don't give me a system. Don't give me a national system. We've had enough of them. I don't want you to tell me what system I have to push my buttons and all that kind of stuff. Give me an infrastructure. Give me something that we can work with, something that will interface with what we're already doing. Within Wales, whilst it is small, the organisation is at different levels of data maturity. So we had to make sure that we could fit in with all. This was part of the NDR, the National Data Resource. It was part of our value-based healthcare approach. So this is a system of systems. The ethos is locally owned, locally driven data informing national picture. And this falls in line with that. Don't give me a system. They didn't want some information sitting somewhere else that they couldn't get to. So this was how to engage, how to give local ownership, how to give local passion, local drive to a national problem that we needed to solve. So this was all in development, irrespective of Scan4Safety, and what we've done is we've worked in with that to make sure that we don't have to solve everything that where good practice has happened. It still goes on. And then I suppose it then flows into where we stand in relation to MDIS. And the view at the minute is that we will collate within Wales and feed out to MDIS. And I think Baroness Cumberledge touched upon it yesterday in relation to consent. The agreement is between the Welsh public and the Welsh NHS, and we want to make sure that isn't jeopardised by where the information goes and who uses it. However, we're completely on board with it. The original NDR goals were aligned with MDIS. The data that we need to collect for it is aligned. And as you can see, where our Scan4Safety programme fits alongside a lot of other areas where PREMS, clinical information is being pulled together to make sure that all of this comes together. A lot of this is still in the idea space, the build. Digital Health and Care Wales are building and leading a lot of this, and we've got the pelvic floor pilots that we're working with Swansea Bay Health Board on, which was a shock to us originally, that it goes a lot further than what we thought Scan4Safety and what MDIS would be. So lots and lots of information where devices aren't even being used, they're being collected. So again, that pushes the scope in there. Very, very busy slide, but where do the standards fit? So we've got lots and lots of different work streams working out how we get the GS1 standards coming through. So the GTINs, we're procurement, we do procurement, we load all the catalogues. So thankfully my teams, we've mandated them to collect GTINs. I think we, just from the first 4 areas that we've done, orthopedics, cardiology, radiology, endoscopy, we've got just over 300,000 GTINs that we've collected from industry. So that's good. That's all going into Oracle to start to be used and fed into the different systems. GLNs, we're working with each of the heads of estates, the directors of estates across Wales, to allocate GLNs to the whole infrastructure. Not as good as Oracle. We don't have one CAD system across Wales. We've got at least 3 or 4 major systems, as well as one health board uses spreadsheets. So again, that's not ideal, but we know what the task in hand. GSRN, as I mentioned before, we pay everyone. So we've got everybody's details in Wales. So the challenge there is to how do we use GSRNs in relation to a master staff index, and similarly through Digital Health and Care Wales, we've got a master patient index. So again, we're looking at how we can use that. NHS number is always the one to use, but when people pitch up, they don't necessarily have them. And some of the deprived areas that we've got in Wales, the people, quite a few people still are illiterate in some of those areas. So asking for an NHS number is still not possible. So getting those is still a challenge. So last slide, and I've seen my little timer click over that I've done my time. So just to conclude, from a Wales's perspective, we've got good support from Welsh Government. We've got good support from the NHS in Wales. Sneakily by Alan Brace. If anybody knows Alan Brace was the finance director at Welsh Government when all of this was coming through. There was noise that Welsh Government would fund it. So it's interestingly, all the DOFs across Wales all supported it. And then when it came to the business case at the end, Alan Brace said, yeah, but we're only going to pay part of it, you're going to pay the rest. And the NHS was like, well, what? Just a minute, I thought this was a national programme. And Alan's view was, you need skin in the game. This can't just happen over there and you not be interested in it. This needs to be embedded within your organisations. You need to be driving this as well. So what we came with the compromise, the Welsh Government's paid all the capital. They paid for the first 2 years of revenue, and then it will come back into the normal way of working from year 3 onwards, which gets buy-in from the NHS. So I'm not going to go through all of them because I'm conscious I'm over time, but as I mentioned before, I'm a bit flippant about stealing people's ideas, but this is a brilliant event and for generating those ideas, for those exchanges. And last apology, I'm not going to stop stealing your good ideas. I think we need to bring them all together. We need to make sure that we all move together in this. So, diolch yn fawr. Thank you very much.
Thanks very much, Andrew. Maybe you don't need to apologise for stealing ideas. The whole idea of conferences like this is to share learning and information, not to reinvent the wheel, not to make the same mistake 14 times, but to share knowledge. So I think that's fantastic. And great to hear how it's being rolled out across Wales.